Logotherapy as a technique. A realistic fear, like the fear of death, cannot be tranquilized away by its psychodynamic interpretation. On the other hand, a neurotic fear, such as agoraphobia, cannot be cured by philosophical understanding. However, logotherapy has developed a special technique to handle such cases too. To understand what is going on whenever this technique is used, we take as a starting point a condition which is frequently observed in neurotic individuals, namely anticipatory anxiety. It is characteristic of this fear that it produces precisely that of which the patient is afraid. An individual, for example, who is afraid of blushing when he enters a large room and faces many people, will actually be more prone to blush under these circumstances. In this context, one might amend the saying, "The wish is father to the thought," to "The fear is mother of the event." Ironically enough, in the same way that fear brings to pass what one is afraid of, likewise a forced intention makes impossible what one forcibly wishes. This excessive intention, or hyperintention as I call it, can be observed particularly in cases of sexual neurosis. The more a man tries to demonstrate his sexual potency, or a woman her ability to experience orgasm, the less they are able to succeed. Pleasure is and must remain a side effect or byproduct, and is destroyed and spoiled to the degree to which it is made a goal in itself. In addition to excessive intention as described above, excessive attention, or hyper-reflection as it is called in logotherapy, may also be pathogenic, that is, lead to sickness. The following clinical report will indicate what I mean. A young woman came to me complaining of being frigid. The case history showed that in her childhood she had been sexually abused by her father. However, it had not been this traumatic experience in itself which had eventuated her sexual neurosis, as could easily be evidenced. For it turned out that, through reading popular psychoanalytic literature, the patient had lived constantly with a fearful expectation of the toll which her traumatic experience would someday take. This anticipatory anxiety resulted both in excessive intention to confirm her femininity and excessive attention centered upon herself rather than upon her partner. This was enough to incapacitate the patient for the peak experience of sexual pleasure, since the orgasm was made an object of intention and an object of attention as well, instead of remaining an unintended effect of unreflected dedication and surrender to the partner. After undergoing short-term logotherapy, the patient's excessive attention and intention of her ability to experience orgasm had been dereflected, to introduce another logotherapeutic term. When her attention was refocused toward the proper object, that is, the partner, orgasm established itself spontaneously. Footnote: in order to treat cases of sexual impotence, a specific logotherapeutic technique has been developed based on the theory of hyperintention and hyperreflection as sketched above. Viktor E. Frankl, The Pleasure Principle and Sexual Neurosis, The International Journal of Sexology, Volume 5, Number 3, 1952, pages 128 to 30. Of course, this cannot be dealt with in this brief presentation of the principles of logotherapy. Logotherapy bases its technique, called paradoxical intention, on the twofold fact that fear brings about that which one is afraid of, and that hyperintention makes impossible what one wishes. In German, I described paradoxical intention as early as 1939. In this approach, the phobic patient is invited to intend, even if only for a moment, precisely that which he fears. Footnote: Viktor E. Frankl's Medikamentösen Unterstützung der Psychotherapie bei Neurosen, Schweizer Archive für Neurologie und Psychiatry, Volume 43, pages 26 to 31. Let me recall a case. A young physician consulted me because of his fear of perspiring. Whenever he expected an outbreak of perspiration, this anticipatory anxiety was enough to precipitate excessive sweating. In order to cut this circle formation, I advised the patient, in the event that sweating should recur, to resolve deliberately to show people how much he could sweat. A week later he returned to report that whenever he met anyone who triggered his anticipatory anxiety, he said to himself, "I only sweated out of a quart before, but now I'm going to pour at least 10 quarts. The result was that, after suffering from his phobia for 4 years, he was able, after a single session, to free himself permanently of it within 1 week. The reader will note that this procedure consists of a reversal of the patient's attitude, inasmuch as his fear is replaced by a paradoxical wish. By this treatment, the wind is taken out of the sails of the anxiety. Such a procedure, however, must make use of the specifically human capacity for self-detachment inherent in a sense of humor. This basic capacity to detach one from oneself is actualized whenever the logotherapeutic technique called paradoxical intention is applied. At the same time, the patient is enabled to put himself at a distance from his own neurosis. A statement consistent with this is found in Gordon W. Allport's book, The Individual and His Religion. The neurotic who learns to laugh at himself may be on the way to self-management, perhaps to cure. Paradoxical intention is the empirical validation and clinical application of Allport's statement. Footnote: New York, The Macmillan Company, 1956, page 92. A few more case reports may serve to clarify this method further. The following patient was a bookkeeper who had been treated by many doctors and in several clinics without any therapeutic success. When he was admitted to my hospital department, he was in extreme despair, confessing that he was close to suicide. For some years he had suffered from a writer's cramp, which had recently become so severe that he was in danger of losing his job. Therefore, only immediate short-term therapy could alleviate the situation. In starting treatment, Dr. Eva Kozdera recommended to the patient that he do just the opposite of what he usually had done, namely, instead of trying to write as neatly and legibly as possible, to write with the worst possible scrawl. He was advised to say to himself, "Now I will show people what a good scribbler I am." And at the moment in which he deliberately tried to scribble, he was unable to do so. "I tried to scrawl, but simply could not do it," he said the next day. Within 48 hours, the patient was in this way freed from his writer's cramp, and remained free for the observation period after he had been treated. He is a happy man again and fully able to work. A similar case, dealing, however, with speaking rather than writing, was related to me by a colleague in the laryngological department of the Vienna Polyclinic Hospital. It was the most severe case of stuttering he had come across in his many years of practice. Never in his life, as far as the stutterer could remember, had he been free from his speech trouble even for a moment, except once. This happened when he was 12 years old and had hooked a ride on a streetcar. When caught by the conductor, he thought that the only way to escape would be to elicit his sympathy, and so he tried to demonstrate that he was just a poor, stuttering boy. At that moment, when he tried to stutter, he was unable to do it. Without meaning to, he had practiced paradoxical intention, though not for therapeutic purposes. However, this presentation should not leave the impression that paradoxical intention is effective only in monosymptomatic cases. By means of this logotherapeutic technique, my staff at the Vienna Polyclinic Hospital has succeeded in bringing relief even in obsessive-compulsive neuroses of a most severe degree and duration. I refer, for instance, to a woman 65 years of age who had suffered for 60 years from a washing compulsion. Dr. Eva Kozdera started logotherapeutic treatment by means of paradoxical intention, and 2 months later the patient was able to lead a normal life. Before admission to the neurological department of the Vienna Polyclinic Hospital, she had confessed, "Life was hell for me." Handicapped by her compulsion and bacteriophobic obsession, she finally remained in bed all day, unable to do any housework. It would not be accurate to say that she is now completely free of symptoms, for an obsession may come to her mind. However, she is able to joke about it, as she says, in short, to apply paradoxical intention. Paradoxical intention can also be applied in cases of sleep disturbance. The fear of sleeplessness results in a hyperintention to fall asleep, which in turn incapacitates the patient to do so. Footnote: the fear of sleeplessness is, in the majority of cases, due to the patient's ignorance of the fact that the organism provides itself by itself with the minimum amount of sleep really needed. To overcome this particular fear, I usually advise the patient not to try to sleep, but rather to try to do just the opposite, that is, to stay awake as long as possible. In other words, the hyperintention to fall asleep, arising from the anticipatory anxiety of not being able to do so, must be replaced by the paradoxical intention not to fall asleep, which soon will be followed by sleep. Paradoxical intention is no panacea, yet it lends itself as a useful tool in treating obsessive-compulsive and phobic conditions, especially in cases with underlying anticipatory anxiety. Moreover, it is a short-term therapeutic device. However, one should not conclude that such a short-term therapy necessarily results in only temporary therapeutic effects. One of the more common illusions of Freudian orthodoxy, to quote the late Emil A. Gutteil, is that the durability of results corresponds to the length of therapy. In my files there is, for instance, the case report of a patient to whom paradoxical intention was administered more than 20 years ago. The therapeutic effect proved to be, nevertheless, a permanent one. Footnote: American Journal of Psychotherapy, 10, 1956, page 134. One of the most remarkable facts is that paradoxical intention is effective regardless of the etiological basis of the case concerned. This confirms a statement once made by Edith Weisskopf-Joelsen. Although traditional psychotherapy has insisted that therapeutic practices have to be based on findings on etiology, it is possible that certain factors might cause neuroses during early childhood, and that entirely different factors might relieve neuroses during adulthood. Footnote: Some comments on a Viennese School of Psychiatry, the Journal of Abnormal and Social Psychology, 51, 1955, pages 701-3. As for the actual causation of neuroses, apart from constitutional elements, whether somatic or psychic in nature, such feedback mechanisms as anticipatory anxiety seem to be a major pathogenic factor. A given symptom is responded to by a phobia. The phobia triggers the symptom, and the symptom, in turn, reinforces the phobia. A similar chain of events, however, can be observed in obsessive-compulsive cases in which the patient fights the ideas which haunt him. Footnote: this is often motivated by the patient's fear that his obsessions indicate an imminent or even actual psychosis. The patient is not aware of the empirical fact that an obsessive-compulsive neurosis is immunizing him against a formal psychosis rather than endangering him in this direction. Thereby, however, he increases their power to disturb him, since pressure precipitates counter-pressure. Again, the symptom is reinforced. On the other hand, as soon as the patient stops fighting his obsessions and instead tries to ridicule them by dealing with them in an ironical way, by applying paradoxical intention, the vicious circle is cut. The symptom diminishes and finally atrophies. In the fortunate case where there is no existential vacuum which invites and elicits the symptom, the patient will not only succeed in ridiculing his neurotic fear, but finally will succeed in completely ignoring it. As we see, anticipatory anxiety has to be counteracted by paradoxical intention. Hyperintention as well as hyperreflection have to be counteracted by dereflection. Dereflection, however, ultimately is not possible except by the patient's orientation toward his specific vocation and mission in life. Footnote: this conviction is supported by Allport, who once said, "As the focus of striving shifts from the conflict to selfless goals, the life as a whole becomes sounder, even though the neurosis may never completely disappear." Opposite, page 95. It is not the neurotic's self-concern, whether pity or contempt, which breaks the circle formation. The cue to cure is self-transcendence.